All right, our next speaker is Madhur Singh. Madhur is the director of EP at UPMC Hammett in Erie. And Madhur is going to talk to us about what if we're stuck between a rock and a hard place and our patient needs anticoagulation, but they also have bleeding risks or high risk lifestyle that makes them, unable to take anticoagulation. Madhur.
Good morning. Thanks for having me. This is wonderful. So I ran the slides with my wife last night. I was at about 31 minutes. I was instructed to do 25 minutes. She told me take some slides out. We compromised like we usually do, and I didn't take any of them out. So let's see if we can get through this. I have no disclosures today. The obligatory atrial fibrillation slide to piggyback off of what Aditya just said. There's a lot of atrial fibrillation. The incidence is going to keep going up. I really like these two maps from the CDC. On the left is the rate of hospitalization for atrial fibrillation in the US in population over the age of 65. On the right is the Medicare beneficiaries as a percentage of the total population. And you can see the overlap in the darker blues, which is the Medicare population, and the darker red, which is higher incidence of hospitalization. So our population is getting older. They're having more atrial fibrillation. And this is reflected. We've looked at our internal data at Hammett. We end up seeing anywhere from 400 to 450 patients per each month with a diagnosis of atrial fibrillation, whether primary or secondary. And why do we care? We care for several reasons, a lot of which Aditya has already alluded to, but the biggest reason we care is because of risk of stroke. Atrial fibrillation, patients with atrial fibrillation tend to have a 5-time higher risk of stroke compared to someone who does not have atrial fibrillation. More importantly, strokes with atrial fibrillation tend to be much more devastating because the size of the thrombus is bigger, which leads to worse morbidity and mortality. And 10 to 20% of the time, the initial diagnosis of atrial fibrillation is made when someone actually gets admitted with a stroke or a mini stroke. And Aditya already pointed this out, anticoagulation has been proven to prevent strokes. It doesn't completely eliminate the risk of stroke. It decreases it by about 66%, and patients do tend to have smaller strokes on anticoagulation. And we're all familiar with the CHA2DS2-VASc score and the class 1 indication for anticoagulation from ACC HRS in patients CHA2DS2-VASc of 2 or women CHA2DS2-VASc of 3 or greater. So why do we start anticoagulation? It's presumed that strokes occur in atrial fibrillation because of clots that form in the left atrial appendage. And the paper that's most frequently quoted for this is this review from 1996, where it was found that 90% of thrombus or clots in the left atrium or intracardiac were found in left atrial appendage in patients with atrial fibrillation. And this was a review of several other studies, and the 90% number comes from, if you do the math, 21 clots were found in the left atrial cavity, 200 found in the left atrial appendage, and ends up being about 90%. So even 25 years ago, the conclusion was these data suggest that left atrial appendage obliteration is a strategy of potential value for stroke prophylaxis in non-rheumatic atrial fibrillations. It's not necessarily a new idea. Do we have an alternative to anticoagulation to prevent stroke? And these are a couple of other papers that I'm highlighting that discuss the importance of resecting the left atrial appendage for prophylaxing against arterial thrombi or ligating the left atrial appendage this is contemporary from 1947 and 1949. So over 50 years we've recognized, and this is from 1955 in the British Medical Journal, once again talking about pathology of left atrial appendage thrombus and preventing a stroke in patients with atrial fibrillation with a left atrial appendage thrombus. And this is why we care. Obviously I'm going to present the most dramatic examples I have, but this is a patient that we've seen within the last year who came in with a stroke. And this was the thrombus in the left atrial appendage. And this on the right is not a Watchman. This was a patient of mine that had come in for a cardioversion. And there is a large thrombus that's pretty much conforming to the left atrial appendage itself. So obviously, this is what leads to the devastating outcomes in patients with atrial fibrillation. And this is what we're trying to prevent. So left atrial appendage as a source of thromboemboli in most patients with atrial fibrillation is the guiding principle behind ligating the appendage, amputating the appendage, occluding the appendage, whatever mechanism you end up going down. And I'll expand on that a little bit. And this is especially important in people who are not able to take anticoagulation. This is a 30,000 view, as Dr. Saba would say. So, we don't have time to go into the nuances of this, but the way left atrial appendage closure is approached in the US is still mostly limited to patients that are unable to take anticoagulation. So this is not a therapy that's available for all comers with atrial fibrillation. And we're gonna go a little bit more into that. So what do I mean by that? A lot of our patients, especially elderly patients, are at increased risk of bleeding. Either they've had GI bleeding, they've had intracranial hemorrhage, they have a tendency to fall, they have anemia of unknown etiology, they're getting constant transfusions, but there's really no clear etiology established. Compliance may be a little bit of a gray zone, but we all know that's an issue. Medication compliance is an issue. Cost could be an issue. Lifestyle could be an issue. All of these have question marks because once again, some of this gets into the gray zone because this is not where the technology has been studied, at least not to date. And if they're having a planned cardiac surgery performed for something else, does it make sense to resect the left atrial appendage at the same time? So as I mentioned earlier, you can ligate it, you can amputate it, or you can occlude the appendage. Ligation and amputation are usually surgical approaches. Occlusion is mostly a percutaneous approach. What do I mean by that? If you're going in for having a mitral valve done or having a maze done or having an open heart, they don't even have to do an atriotomy. Does it make sense just to put a clip on the left atrial appendage at the time of the surgery? My surgical colleagues tell me it's easy to do. I have no experience doing this, obviously, but it doesn't add much time to the procedure. It's a safe procedure to be done, and I think it makes sense. And if they don't have a cardiac surgery plan, that's where this gets a little iffy. Sometimes we do come across patients that are not good candidates even for a Watchman or an amulet device. We'll talk more about that. Then does it make sense just to do a mini thoracotomy and clip the appendage epicardially and not expose them to requiring anticoagulation? And there is some data supporting this. Historically, there wasn't a whole lot of data. This was actually just published in the New England Journal of Medicine last year. It's a randomized trial evaluating occluding the left atrial appendage in patients with known history of atrial fibrillation who are at high risk of stroke, occluding the appendage at the time of the surgery. And the data was promising. There was definitely a stroke risk reduction in patients who had their appendage occluded at the time of the surgery. The caveat is this was not in a patient population that was at high risk for bleed. These were all comers who were having surgery done. And as you notice, 75% of these patients actually remained on anticoagulation even at 3 years of follow-up, but there was still a statistically significant difference in reduction in ischemic strokes. And these are just some of the mechanisms that were utilized to close the appendage. As I mentioned, you can amputate it and oversew it. You can put staples on the appendage. You can put an epicardial clip on the appendage. Our practice is, and our surgical colleagues do this frequently, is if they do end up undergoing this technique, we will still obtain a TEE on these patients about 6 weeks or 3 months after the procedure to make sure that on the endocardial aspect, there are no exposed pectinates, or there's not reconnection, blood still going into the appendage, or there's not a pouch left behind, nothing that could serve as a nidus for a thrombus going forward. And this is reflected in the most current guidelines also. So ACC HRS guidelines give this a 2B indication for closure of the appendage at the time of surgery. And these guidelines came out before the paper that I just presented. So we'll see what happens in that space as time goes on. So that's a surgical way to close the appendage. How about a percutaneous way to close the appendage? I tried to keep this as free of commercial bias as possible, but Watchman is the most common device implanted in the US. So, and we've all heard about Watchman the most, but the Abbott amulet device was just approved by the FDA last fall. So now we have that in addition to Watchman available. And then Lariat device is a very niche device available for closure. And I'll expand on all three of those in a bit. But the most recent update to the AFib guidelines in 2019 does recognize the value of appendage closure. And this now has a 2B indication also for percutaneous appendage closure in select patient population who are unable to take long-term anticoagulation. So Watchman was initially approved by the FDA in 2015. Watchman Flex that you see in parentheses was approved, I want to say about 2 years ago, which was just an updated version of the previous Watchman device, a lot more safer device when it comes to implantation. But it's been used in Europe since 2005. And the amulet device, as I just mentioned, was just approved last year, but once again, has been in use in Europe for over a decade at this point. And then the Lariat device has an interesting story behind it. This was initially approved as a percutaneous stitch, but I don't think that the company ever disclosed to the FDA that they were going to start marketing this as an epicardial appendage closure device. So it wasn't really studied for that, although it did ultimately get utilized for that, and got a very stern warning from the FDA when patients started having severe outcomes because the device wasn't studied. So the outcomes included death, laceration of the heart, complete left atrial appendage detachment from the heart, et cetera, et cetera. And the FDA gave a stern warning to be aware that the safety and effectiveness of the lariat suture delivery device to close the left atrial appendage and prevent stroke in patients with AFib has not been established. So this is a very niche product. This is usually reserved for our patients who are just absolutely not a candidate for endovascular left atrial appendage closure because they can't take anticoagulation. And they're even not candidates for epicardial closure, which would also be almost be my second line therapy at this point before I would consider sending someone for a lariat device. So that brings us to the Watchman device. As I said, this is the most commonly used device. It has the highest data supporting its use. And we've been using it since 2016 in Hammett, but it was approved in 2015, as I mentioned to you. On the left of the screen is the previous generation device. On the right of the screen is the Watchman Flex device. Why does it make a difference? It's just a safer device, as I mentioned, to implant. This had an open cage. This is the side that faces the left atrial appendage. Obviously, much higher risk of perforation because of this. This has a closed cage design. It makes it very much easier to manipulate this in the appendage and not have issues with perforation. That's the biggest thing that early on was the complication of the Watchman implant was perforation. In addition, just anchors better in the appendage. So it's just a much better version of the initial device. It's a self-expandable nitinol cage. Nitinol has a very interesting history. If I have time at the end of the talk, we can maybe talk about that for 30 seconds. So the initial trial for this was Protect AF in 2014. FDA looked at it, said we need more data. Then Prevail was published, and FDA did end up approving this for implant, as I said, in 2015. But there is much more data than that supports the use of the Watchman device. That's beyond the scope of this talk. But there's just to highlight the amount of research that's been done into the device. So who gets the Watchman? When FDA initially approved it, it was approved for patients who were at high risk for stroke based on their CHADS or CHADS-VASc score and are recommended for anticoagulation therapy. They were deemed to be suitable candidates for warfarin by their physicians, and they have an appropriate rationale to seek non-pharmacological alternative to warfarin therapy. And that's important. Taking into account the safety and effectiveness of the device compared to warfarin therapy. So that's verbatim from the FDA. The reason I mentioned that is that was much more looser than what the trials had looked at and then what CMS was willing to cover. So CMS agreed, yes, they have to be high risk for stroke. There has to be a formal shared decision-making. That's just something that happens on the back end where we have to consult with a referring physician, whether it's a primary care physician, a cardiologist, managing the patient, saying, yes, we agree, this is an appropriate treatment for this patient, and it's reasonable to offer this treatment. But the other thing that CMS put in there is the suitability for short-term warfarin, but deemed unable to take long-term oral anticoagulation. So this was defined as second-line therapy to oral anticoagulation. I think most of us in cardiology and EP agree that anticoagulation is still the gold standard. We are not trying to replace anticoagulation with appendage closure, mostly because there's lack of data. 5 years from now, things may change. We'll talk about that briefly at the end of the talk. So CMS, which is responsible for reimbursing, says this is supposed to be reserved for patients who are unable to take anticoagulation. Just to kind of give you a sense of what we're doing when we're putting in the Watchman device. So the sheath is sitting in the left atrial appendage. Usually we'll go transeptal, we'll get access to the appendage. There's a pigtail in the appendage. We'll inject contrast in the appendage, and we take measurements based on this. And then there's a TEE probe down, and our echo colleagues measure the appendage for us and kind of get a sense of what size device we need to put in, because this comes in different sizes. It's not one device fits all. There's 5 different sizes. And once we've made that determination, this is the device actually being deployed. So if the reason I highlighted the Watchman Flex is you see the distal end, which is what's actually facing the appendage, is very atraumatic at this point. It doesn't have the open cage design anymore, and hence much less likelihood of perforation. So the risk of perforation with the Watchman Flex is 1 in 400. Knock on wood, we do about 100 a year. We have not had one ever since we've started using the Watchman Flex device. And ultimately at the end, this is what it ends up looking like, right? The device is in place, we're injecting contrast, and this is what you want. The appendage is completely occluded at the os. thrombus forms back here, as long as it doesn't escape and go into the systemic circulation, this is how we're minimizing stroke risk. Post-Watchman, there is still a requirement for short-term anticoagulation, and that ends up being the Achilles heel sometimes for some of these patients, because the current requirement is still 6 weeks of anticoagulation after the Watchman is implanted. Then we perform a TEE to make sure that there is no thrombus on the device, and to make sure that there are no leaks around the device. So if the Watchman is not opposing the tissue adequately, you could have gaps and blood could still communicate with the appendage, and the size of the leak matters. So less than 5 millimeters we're willing to accept. If it's more than 5 millimeters, that could be problematic. That's a risk for developing thrombus. And then we may need to extend anticoagulation, repeat the TEE to make sure that that's not an issue. But as long as the 6-week TEE looks good, which is the case in 95% of the patients, they get to come off their anticoagulation. Their anticoagulation gets replaced by Plavix. So they're on aspirin and Plavix for about 4 more months. And at 6 months, the destination therapy is just a baby aspirin. Initially, the initial anticoagulation regimen was required to be warfarin. There's new published data that DOACs are just as safe. So our approach now is DOAC plus aspirin for most of our patients, outside of some nuances where we may still end up choosing warfarin for the patients. Now, the requirement for anticoagulation, as I said, is still the Achilles heel. And there is some variation on how this is practiced across the Atlantic. They are already more aggressive in treating patients with dual antiplatelet therapy up front and foregoing the anticoagulation piece completely, especially in patients who are at high risk for bleeding. This is being studied. The ASAP-2 trial is looking at this specific question. I suspect, this is a dynamic, very, very quickly evolving area. I suspect that there will be some change in this requirement for anticoagulation in the near future, even if it's for a certain subset of patients who are getting the Watchman implanted. So just to reiterate, the optimal antithrombotic regimen and duration after left atrial appendage closure is still under debate, and it's possibly patient-specific. Oral anticoagulation does remain the standard of care in patients at low bleeding risk, but the use of antiplatelet agents alone may be indicated in some clinical scenarios in patients after Watchman implant. And why do we care? As I said, this is why we care, right? If you develop a clot, so this is a thrombus sitting on the Watchman. This is a patient I did 2 years ago, maybe 3, who was in the hospital 4 times a year with GI bleeding. And we had a period of 3 months where she had not bled on anticoagulation, and we elected to proceed with the Watchman device. Unfortunately, 2 weeks after the implant, she ended up getting admitted to the hospital with a GI bleed, and her anticoagulation was stopped. And then this was her 6th, and it was restarted, but there was an interruption in her anticoagulation, and it was restarted. And at 6 weeks, she had a thrombus. And now I think I made her worse than we first started, because here is someone who's bleeding 4 times a year. And unfortunately, I'm committing her to ongoing anticoagulation, keeping my fingers crossed she doesn't bleed for another 3 to 4 months, and allowing this clot to resolve. It actually didn't go away for almost a year. Thankfully, she did not bleed. She's off anticoagulation. She's only on an aspirin at this point, and her 1-year TEE looked fine. So she's done okay, but this is the concern, is device thrombus and potentially making patients worse than when you first started off. And the incidence of device thrombus on the Watchman is about 3 to 4%. You can do everything correctly, not stop anticoagulation, et cetera, and this 3 to 4% number just sticks around, which is becoming a headache. Are there predictors? There are, but there are no good predictors. There's no good CHA2DS2-VASc or Has-Bled score that helps us figure out who's going to end up with the device-related thrombus. We do know that if there's premature interruption in anticoagulation, that probably is one of the reasons why this could happen. But there's also signal in the data. This was published in JACC, I think last year or 2 years ago, that non-paroxysmal atrial fibrillation is probably a risk factor for developing thrombus. The left atrial size, which is a corollary to just slow flow in the left atrium and the left atrial appendage. If you've had a previous thrombus in the left atrial appendage, chronic kidney disease, pericardial effusion, and then from a technical standpoint, the implantation depth, depending on where we end up placing the Watchman in relation to the Coumadin ridge, could be an issue, or if you don't size the device properly. But these are guesses. I don't think we have a really good understanding still of what promotes the device-related thrombus. So because of that, this is not a device for everyone. I think I mentioned that to you earlier. This is for a very select patient population. Could this one day become the device for everyone? I think that's where the field is heading. The Champion trial is currently looking at that. It's enrolling patients, and I think it's supposed to complete enrollment in 2025, and UPMC is one of the enrolling sites. And it's looking at this question, can we offer a Watchman to all comers, not patients who are at high risk for bleeding? So you have to be able to be randomized to oral anticoagulation versus a Watchman device, and see what happens. We've enrolled 5 patients at Hammett so far, and we're just one of the UPMC centers that's enrolling for this. So I'm excited, lots happening in this space, and let's see what happens in 2025. And the reason, as I mentioned, we're not using it for everyone is life years observed in Watchman patients are only a fraction of those on anticoagulation. The data available for anticoagulation for patients who are not high risk for bleeding is just so much more robust. And this was an expert analysis done by our own Dr. Estes. It was published in ACC in 2016, soon after the Watchman device was implanted. So I think this is an evolving field. Let's give it time. Let's give it a few years and see what happens. Just to keep this free of commercial bias, let's talk about the Abbott Amulet device. So this was just released by the FDA, approved by the FDA last year. The concept is the same. You have a mechanical device that's occluding the ostium of the atrium. Appendage thrombus forms back here. It's not able to escape and go into the circulation. There are some nuances to the device. There's some benefits. It does not require short-term anticoagulation after implant. You can get away with just dual antiplatelet therapy. Some appendage anatomies are challenging to approach with the Watchman device because there's a certain amount of depth that's necessary. That's less of an issue with the Amulet device because that depth is not necessary. I think we're going to start hearing more about the Amulet device. It's still in limited release, but once it gets into the hands of more people, I think we'll start to hear more about this. So who shouldn't get appendage closures? I've talked about who should get it, but let's comment on this also. Obviously, if you don't meet criteria for appendage closure, you shouldn't get it, meaning your CHADS VASC is too low to even require anticoagulation. But once a year, we'll end up seeing a patient who doesn't even have AFib who gets referred for Watchman. Obviously, you have to have atrial fibrillation to be considered for the Watchman device. Excuse me, if you have valvular atrial fibrillation, this is not the right device for you. If you have poor life expectancy, 1 to 2 years, I'm not sure that this necessarily makes sense, similar to placing an ICD in that patient population. If you have contraindication to short-term anticoagulation, that's the Achilles heel. I think we've beaten that horse to death, so I'm going to go past that. If you have a left atrial appendage thrombus, we can't put a device in there, obviously, for the risk of dislodging the thrombus. If you have unsuitable anatomy, as I told you, there's some nuances to what the appendage looks like in terms of whether we're able to place a device or not. If you have a mechanical valve, or if you have other reason to require anticoagulation, if you have a DVT, you have LV thrombus, then it doesn't make sense to put in a Watchman device in effort to try to get off the anticoagulation. And then some of these are really gray areas. We don't know what to do, or sometimes we think a patient is appropriate for Watchman or maybe not appropriate. And it's nice to have a forum. So at UPMC, what we have is most all implanting sites within UPMC have a virtual forum that meets once a week. And we get an email saying, hey, do you have a gray zone Watchman patient that you'd like to run by your colleagues and make sure that this is an appropriate thing to do? And this is very helpful to have because, once again, as I said, some of these cases end up being gray area. And if you have support from your colleagues to do it or not do it, it's just more justifiable way to approach the case. What are the pitfalls to do in the Watchman device? Well, number one, you can get a device thrombus, as I mentioned, and that's still the Achilles heel of this. Incomplete surgical ligation, excision, or clipping, and that's why I mentioned earlier, if they have a surgical procedure, at least my practice is, before stopping anticoagulation, have them come in for a TEE 6 weeks or 3 months after to make sure that this device is, that the appendage is truly occluded or excluded. You can still get thrombus 10% of the time in the atrial body itself. So this only prevents strokes related to left atrial appendage thrombus. And there's procedural risks. When the device first came out, there was much higher risk of device embolization, pericardial effusion, risk of stroke. We have had less than 1% risk. We've never had an embolized device. We may have had 1 stroke and 2 pericardial effusion in the last 3 years that we've been doing this. So it's a much safer procedure. There's definitely a learning curve to it, but once you get past that, it's a much safer procedure. I do have 1 more minute left, so I'm gonna skip to my thank you slide. But nitinol, just a historical perspective, I was so fascinated by this. What is nitinol? I've done enough Watchman talks at this point that this keeps coming up. So I finally decided to look this up. Nitinol is a nickel and titanium alloy that was actually originally developed by the Naval Ordnance Laboratory, which does not exist anymore. Its office is currently taken by the FDA. So it's a nickel titanium alloy discovered at the Naval Ordnance Laboratory. What they were looking for was a nose cone for nuclear ballistic missiles that they could launch from submarines. And they realized as they were working with this material that the properties of the material changed significantly depending on the temperature. And that's why the properties of this change significantly once it's in the body and exposed to warm blood as opposed to being outside the body. So 24 minutes and 51 seconds, Dr. Estes. That's all I have.
Thank you, Madhur. You know, as a general rule, always listen to your wife. Okay, just put it out there. But you did great with a lot of material, and you went through all those slides in good time. So open for questions. I'm going to start with a question, a couple of questions that I'm condensing from the chat. So Dr. Tumalapalli asked, are all surgical exclusions created equal, meaning that clipping versus stapling versus cutting and suturing versus sewing? And then you kind of answered the other question when you said you always get a TEE before you stop anticoagulation. So that is taken care of, but what are your thoughts?
I think you have to have confidence in the surgeon you're working with. And I think you have to have a good working relationship with the surgeon and understand what they're planning on doing. Are they clipping? Are they cutting and oversewing the appendage? Are they putting staples? That's, I think, the first most important piece of this. Are they all created equal? I think as long as the appendage is excluded adequately, that means there is no pectinate exposed on the endocardial aspect. There's no pouch. There's no flow going into the appendage. Yeah, I see no reason why they're not all created equal. But to confirm that they're all created equal, that's why I advocate for a TE on almost all these patients before stopping anticoagulation.
Okay, quick question from Jessica. For patients who are allergic to nickel, is that a contraindication for a?
I suppose it would be. I've not come across that, but I don't know if they're making gold-plated Watchmen. But I depending on the nature of
don't
the
give anybody any ideas for surcharge.
Yeah, right. But I suspect depending on the nature of the allergy, you'd have to take that into consideration.
Yeah. A quick one. You mentioned the amulet device.
Yeah.
By the way, there is the Catalyst study, which is the equivalent of Champion for the amulet, and UPMC is going to be part of it. But what are your thoughts about choosing this device versus that device in terms of anatomy, or what would drive you eventually?
I have not implanted the amulet device, but I read about it. And actually, Dr. Jain and I just talked about it the other day. I think the biggest advantage is this whole 6-week of anticoagulation requirement. You can forego that with the amulet device, although that may be changing for the Watchman also. As I said, there's a lot happening in this space. So that requirement may go away for the Watchman device. But I think that's number one. But number two is the sizes of the device available. It's applicable to a slightly bigger appendage anatomy at the osteo level. But in addition, as I said, if you don't have enough depth, the amulet device does not require as much depth. So there's certain anatomical considerations that could make it a more reasonable option.
Thank you, Madhur. One more to squeeze in, but very quick answer. Somebody, Dilip is asking, is ice better than TEE potentially to make sure that you don't have leakage?
Yeah, there are operators that will use ice as part of their implant as opposed to TEE. There's a couple of disadvantages. It does require a double transeptal because you're placing the ice in the left atrium. But more importantly, you have to understand what you're looking at. I'm not an echocardiographer. I'm very comfortable with ice to do a transeptal puncture. I'm very comfortable with ice to do AFib ablations and VT ablations. I'm not comfortable with ice to be able to evaluate the appendage. I have spoken with people who exclusively use ice. They're very comfortable with ice, and I think their outcomes are just as good as with TEE. I still trust having an imaging colleague in the room, kind of looking at the color, making sure there's no leak, doing the compression measurements and everything. But to answer Dilip's question, yes, it's a very reasonable way to do this. It does help with cost containment, et cetera, but there is also a learning curve of using the ice for appendage closure for the operator.
Perfect. Thank you, Madhur.
Absolutely. Thanks,
I
guys.
ask you to join me here because I'm getting lonely.